These are things that we're doing to try to help, but they can have their own potential drawbacks too. That's a real concern about if someone's a potential candidate for surgery and removing that area, that's great, but what if it overlaps with an area that they need? I mentioned before, we're studying normal brain activity in a lot of these patients with these electrodes implanted, but some of those areas are abnormal, and so they may have some residual function that we're using to try to understand how the brain works in general.
Fellow Homo sapiens, welcome to or welcome back to Epilepsy Sparks Insights. When people think of epilepsy, they usually think of seizures alone. Seriously, this is true of many actually in the medical field too. What epileptologists and epilepsy nurses and people with an epilepsy can tell you is that it is often way more than seizures. And the challenges faced by so many of us include issues with memory and cognition. Last week, star epileptologist and neuroscientist Jon Kleen gave us a brilliant intro into our fascinating little seahorse, the hippocampus, and the challenges it commonly faces with temporal lobe epilepsy. Today, Jon and I chat about the benefits of intracranial recordings for surgery workups, neuroplasticity, and the pros and cons of certain treatments when it comes to cognition, and more. Please don't forget to like, comment, and subscribe to the channel if you haven't already, so that we can spread the word and education about the epilepsies to more and more people.
My name is Jon Kleen. I'm an epileptologist over at UCSF Medical Center in San Francisco, California. And so I do a bunch of different things, but kind of two main domains. One is the clinician. So I see patients with epilepsy in both the clinic, so the outpatient side, and then also the inpatient side. We have an epilepsy monitoring unit, and we also read the EEG for anyone who's got an EEG on the entire hospital, ICUs, etc.
Do you know what I've heard from other people, and I totally relate to this, is that sometimes they'll come to an appointment, and if they haven't written down what they were going to say, they'll forget what they were going to say. And so it can be really hard to actually, ironically, remember that they need to say something about their memory. And yeah, I mean, I guess you come across, but you're very aware of this potentially being an issue. So I imagine you bring this up in appointments. Do you bring up things about memory and cognition and overall life rather than solely looking at seizure control?
And often I'll just notice it in the visit. Sometimes they'll just tell me I'll ask them how was the last couple of weeks for you? Any increase in seizures? And they'll say, they'll look over at their parents if they're there, their friend in the room, just am I having seizures? And they just have such trouble remembering. So I'll ask about it. I'll probe a little bit more in terms of what domains they're having trouble with. A lot of times, like I said, word finding difficulty is one aspect we hear a lot, but also just, a conversation I had last week or last month, or I was in class all last week and I could barely remember any of this stuff. I had just study so hard later. And those are big challenges. These are really important times in everybody's life. Our whole life is important, but I have people in college, or in grad school, or working a really high level job. These are areas where they really need their brain, their noggin, as much as possible. And it's really important to hear that and to work with them on it. And, I mentioned adjusting medications as a possibility for things, but again, we don't really have great evidence that medicine changes are going to be a slam dunk way to improve someone's cognition. We do know that if they're having seizures, that's definitely going to tire out those brain areas more. So it's another big reason to get seizures controlled. But there's no medicines that I could just say, oh, here, take this pill, it's going to improve your cognition at this point. Hoping that'll be the case down the road. That'd be wonderful for other neurological disorders as well. There aren't some. Other things, like neurostimulation, that could potentially help in the future as long as we get better targets. That's one of the focuses in my lab, is not just saying, oh, let's stimulate and see what happens to try to improve cognition, but let's actually understand the network in a lot more detailed way to get better targets from the get-go, things that are going to be more high yield to improve cognition. But
I was going to ask you more about your lab and in your focus or foci at the moment, because we can say cognition is it's quite a broad statement. What are you focusing on right now?
So we actually study that phenomenon I mentioned before, transient cognitive impairment. We have studied that. I studied that a lot in the past, and we've studied it more recently as well. But we're also looking more into the mechanisms of it. For example, when you have a spike in one area, the brain is highly interconnected, and so it can propagate to other areas of the brain. And those other areas are all of a sudden getting sort of a pulse of information that is sort of scrambled, and that's got to throw things off a little bit. Right. So we're trying to understand whether the effects of spikes are not just local to where they occur, but perhaps in downstream interconnected areas as well. And for that, we study intracranial recordings a lot. These are recordings that are only done in patients with severe epilepsy in whom we think we could really pinpoint the location of the seizures where they start.
Often done prior to surgery, right?
Exactly, yeah. And it's a surgery in itself in terms of implanting the electrodes. But it's really important also just to capture a seizure happening on those electrodes. So they stay with us in the monitoring unit, and we get that captured, and then they go, once we pinpoint where it is, we can take them to the operating room and hopefully remove that area that's just causing trouble and not contributing significantly to their daily function, their cognitive function.
So you can be more specific in what you remove rather than, just getting a big spoon and scooping out the whole lobe. You can take out just the bits you need to. Is that kind of it?
That's exactly right. And, it's a really important surgery because, like I said before, for some people we, quote, cure. And, again, cure is like a very broad word to use, but stop the seizures in over half the patients, sometimes like even 2/3 or more of the patients that go for surgery, depending on the type of resection, again, like meaning resection, just removing the bad area that we do. So that's a great thing that can happen for patients. But along the course of it, they're having recordings inside their brain, and they're hanging out in the monitoring unit with us, and with amazing staff. Of course, you need a really highly trained 24/7 staff to make sure that the patients are safe, and all that if they have a seizure. But a lot of times the patients will just be hanging out and kind of bored, to be honest, and they'll say they'll want to participate and volunteer for the tasks. And if they do, then we're like, yeah, sure, can you name a couple of these pictures, or can you do this task where you listen to these beeps that are going to happen? And to them it's just maybe passing time, but they know that it also is contributing to super important research for people with epilepsy, for people, just a lot of people, because we're trying to understand memory. Colleagues of mine are trying to understand language deeply, but these are electrodes actually on top of or in the brain tissue, so it's an unprecedented way to get highly detailed information about how the brain works.
So exciting. And I speak to heaps of patients who will say, mate, totally up for it. If I can help in any way, why not? Because there can be some of the people who understand the impact on lives of so many other people. And they don't just affect the people with the diagnosis. I'm sure you come across like they really impact families and partners and things like that as well. Sometimes even more, dare I say it, than the actual patient themselves.
And sometimes the patients will tell me that they feel terrible, that their family members have to help them with all these different things, remembering the medicines. If they're sometimes, isn't that wild? If you miss your medicines, you're more likely to have seizures, and that's going to affect your cognition. But coming back around, remembering your medicines in the first place, you need your cognition for that and your memory.
And also sometimes it feels like I need to have the cognition that you're taking away from me to take these drugs again, which often negatively impact my quality of life anyway. Mm-hmm. And then when you're talking about surgery, okay, great if 70% or so generally of people might not have seizures anymore, but then they may have even greater loss of cognitive function because of the surgery, maybe, and that you don't necessarily just come off medications just because you've had surgery anyway. So it's not like a great big gold star just to have the surgery. It's not, because the epilepsy and cognitive issues really can impact a person's life. It's not just about the seizures.
These are things that we're doing to try to help, but they can have their own potential drawbacks too. That's a real concern about if someone's a potential candidate for surgery and removing that area, that's great. But what if it overlaps with an area that they need? I mentioned before, we're studying normal brain activity in a lot of these patients with these electrodes implanted, but some of those areas are abnormal. And so they may have some residual function that we're using to try to understand how the brain works in general. But that's a potential bad thing if this bad area is overlapping with the good area, or especially areas that the person needs in their everyday life that they will really, really notice if they have problems with. So speech, language, if we have seizure onset zone areas in the language cortex, that's a super obvious deficit that would happen later. Luckily, we don't just kind of cross our fingers, right? There's a lot of ways that we are very careful about the potential tissue that we would remove in a surgery. And we do very formal testing on that. We can do stimulation mapping, where we stimulate pairs of electrodes and try to pinpoint like where the actual needed cortex or needed area of the brain is compared to the area that the patient may not need. With epilepsy, we'll see a lot of remapping actually over the course of years to decades, where the brain kind of learns that this area is not really functioning well. So let's shift that over to the complete other side, or let's use like this sort of strategy that depends more on this area of the brain instead of this area to get around this problem that I'm encountering in my daily life.
Do you see that in adults as well? Because I know that we talk about, plasticity all the time, and it's quite a cool word, but there are certainly limitations, right? And the older we get, the less that it's not as easy necessarily to use another part of the brain, or it can take a lot longer. So, but do you see like this happening in older patients as well as younger ones?
To an extent, yeah. I mean, it really depends on the age a lot of times. So the older someone is, getting into like the 30s, 40s, 50s, and beyond, it's even tougher for them to just sort of regain that function over time. But it is definitely, you definitely don't want to even bother, or not bother, or you definitely want to try to improve these functions, right? So we always would have them work with speech therapists, like professional people after something like a surgery to improve that function. There's not like a pill we can be like, oh, you have memory impairments in epilepsy? Sure, this pill will take care of that. We don't have a stimulation way to do it right now. There's stimulation for tremor. There's stimulation for a lot of other, for seizures too. But to improve cognition directly, there's nothing that exists quite yet that's certainly not FDA approved. Hopefully we'll get there someday. But what we do have are certain things that we know is going to help. One is, of course, reducing seizures as much as we can. And then two is like finding better medicines that aren't going to give you side effects, optimizing sleep, reducing stress. But to actively manage cognitive impairment, there is one thing that's been up and coming kind of in the last 15 years called HOBSCOTCH. I don't know if you ever heard about it, but it's through the CDC. So it's funded by government organization. Home-based self-management and cognitive training changes lives. That's it. But it's basically like it's like a 10-session program. You meet with a person like every week, and it's kind of like therapy in a way, like mental health therapy, but instead you focus on memory and cognition. And I send patients to this a lot because they try to actually reduce the cost or get no cost if possible. There's even providers that can provide, like neuropsychologists and nurse practitioners. Other people can provide it, but the idea is to basically give evidence-based techniques to help the person self-manage their cognitive impairments. So memory strategies, not just like, make a list, but other things with evidence behind them, like new tips, tricks. You get like homework between those visits. And again, it's all over Zoom now, basically. So it's really convenient, like kind of wherever you are in the world. But that's definitely up and coming more recently. And I've, the majority of my patients say that it at least helped to some degree. Some patients like rave about it. But the reason I like it is, again, it's evidence-based, right? It's not just like some program that somebody made, it's like evidence behind it. And it's also, they try to reduce the cost or get it like to no cost if possible, particularly since it's funded through the CDC.
Is it at all accessible to people outside of the US?
I know that the HOBSCOTCH folks are trying to expand. We've got there's like a big sort of network they're building, and UCSF is like one of the sites that we're implementing this in a more streamlined way just to increase patient access. But it's currently focused on, broadening from like the East Coast or like the Northeast into like the rest of the United States. But absolutely, it should be global, in my opinion, because again, it's like remote based or just phone based even. Yeah, and anybody could benefit that way. So I have a feeling it will probably become that way eventually, because it just seems to have like accelerated a lot.
It sounds amazing, especially for people who, loads of people don't live close to the hospital, right? Or they struggle to get to the hospital for, lack of public transport or whatever, or they live in a remote area of a country, where they're, lucky if they've got Wi-Fi. So
they're going to have cognitive impairments affecting them, and they deserve treatment, with whatever we have. And
it's a great investment, I imagine. Well, gosh, I'm promoting this already, but something like this is a great investment if it helps people, because you're going to get people, better mental health as well, on fewer drugs. Probably the same for their families. You're going to have more people in work, if they're more confident to actually go out or more confident to socialize and just have better communities. I think people forget how important it is for us to have good enough cognitive function that gives you good quality of life?
There's definitely indirect effects that we see. And, HOBSCOTCH is focused on like the memory outcomes in particular, and hasn't like, they've got other programs through the CDC for epilepsy that are based on, mental health and things. But I totally agree. And I've heard from patients that, improving memory, improving cognition, however you do it, is probably just going to increase confidence. It's going to improve just quality of life in general. That's going to hopefully indirectly contribute to maybe improving stress, anxiety, mental health, mood. Again, we'd have to like look at that in a formal way with studies to understand exactly how much, but I definitely hear it from patients.
And reduce seizure frequency because of all that.
Imagine remembering your medications instead of missing I had a patient a couple months ago that just said, oh, I miss medicines once in a while. Yeah, maybe about 10% of the time. I'm like, 10%? That's a lot. That's a huge amount. But imagine, and he was, that person was having some seizures, like breakthrough here and there. But if that person could be taking all their medicines and not missing any doses because of their memory issues, we could, imagine much more impact, right? So, just work with that person on alarms on the phone, having like the sort of pill box for the AM and PM, and then, emphasizing again, like self-management programs, like HOBSCOTCH again, and I'm not like, I don't have grant funding on HOBSCOTCH. I'm helping with one of the studies that they're doing to try to implement it on a broader scope. But I'm not, I'm not like a paid representative of HOBSCOTCH by any means. But certainly, younger adults, they're going to have sort of more plasticity ability, really, to kind of remap functions or to learn new strategies more dynamically that will help address these things and have that kind of laid down permanently for the rest of their life in terms of how to get around these problems. But the best scenarios are often with young kids, especially like quite young kids, who have tons of plasticity happening and a lot higher rates of neurogenesis. Like birth of new neurons compared to adults. That drops off quite precipitously, even through childhood.
It's easy for me to say, but like if I was younger and I had been given the opportunity to have a resection when I was in my late teens, dude, do it. I've totally done it. I was having so many accidents, injuries. I fell on a railway line during rush hour.
Oh my gosh.
I fell off my bike into the middle of the road.
There's so many, injury potentials. Yeah, gosh. Driving is the hottest topic, I'd say, in the clinic with, well, not for everybody, but certain patients just feel so passionate about driving. It is such a big part of independence. But, there's been rare cases, and, still to this day and throughout the United States and beyond, if a seizure happens and impairs awareness behind the wheel, it can be terrible. I've heard some very lucky stories too, and not to like digress too much, but again, it does get back to the cognitive issue, right? So it doesn't have to be just a spike. It doesn't have to be like, status epilepticus or permanent impairments. It can be just a focal seizure that's brief, that it could be life-threatening for, multiple people on the road. I have a patient that, described like dropping someone off and then all of a sudden being in their parking garage with a big scrape on the side of their car. And it's like, wow, that was the first event that they noticed.
You must hear stories like this all the time, right? It's just wild.
Some patients will get really passionate about it. And it's really just, we have to have those like deep, long conversations. But I always tell them, look, I'm actually your biggest fan to try to get you back on the road. We just got to get your seizures out of here. So let's, we need this time frame. That's a state law, and it's a really good. It's there for a reason. That gives us a really solid amount of time to change these medicines around, get these things stamped out. So, I just try to make sure they get so worried that I'm going to just go report them and I'm the bad guy. But I'm like, look, I'm with you. Let's like join hands here and get you there.
It means so much to us, and I can see that you properly empathize as well, which is so important. You don't just sympathize, but you empathize, and that's not something that all clinicians have,
I don't know how you can't empathize, because that's like, if I couldn't drive the same thing, I don't drive that much because San Francisco's pretty good for, public transportation, but it's not great. And like, I've just Googled like bus routes with patients too. Like, I'll be like, okay, what's this? Okay, let's see what an Uber costs, like from there to the supermarket, just to try to figure out like what we're going to do, right? Because for the next like, 6 months while we get like the seizures back under control.
Thank you so much to Jon for such a great chat regarding epilepsy and cognition, especially the rather integral part that is memory. Do check out more about Jon and his cool work on the website torierobinson.com, where you can also access his podcast, video, and the transcription of this episode. And if you haven't already, don't forget to like, comment, and subscribe to the channel, share this episode with your friends, colleagues, family members, and see you next week.